All right, guys, welcome to the podcast. I'm MD3.
And I'm MD2.
And today we're going to be talking a little bit about stroke and the importance of documenting your findings so that we can kind of track these patients through the system and also so that we know we're activating strokes appropriately.
Yeah.
So to recognize a stroke, I think we all kind of know the symptoms of a stroke, but when we're also teaching the community, we always talk about the Cincinnati stroke recognition, FAST. So that's face, arms, slurred speech, and then timing is very important. So any sort of facial paralysis or facial droop, any sort of arm weakness or really extremity weakness, and then any sort of slurred speech. So if somebody's really, acting like they're drunk or, can't find their words, those are all reasons that you'd want to think, hey, that might be a stroke.
Right. And if you do think it's a stroke, it's important to document your FAST-ED score either to prove that it is or prove that it isn't. So the FAST-ED score is based off of a lot of the components of the Cincinnati. You've got your face, you've got your arm drift, speech changes, but you also have eye deviation, whether they're both stuck to one side or not, and then you also have denial or neglect, which is essentially where you're like, pinching one side or getting a patient to be aware of one side of their body, and if they're not, then that's an extra point. So the way that scale works is that most of the numbers, except for face, I believe, is 1 to 2. And then 1 point is given for like kind of in between symptoms, and then 2 is given for like complete symptoms. So like if I've got complete arm drift, right, that's going to be 2 points. But if I'm up and then this one kind of slowly drifts a little bit, that'd be like 1, right? So I'm not great at memorizing a lot of scoring systems, but I like this one because it's kind of easy to backtrack in my mind.
It is too, but also, I'm not one who's afraid of pulling up a phone app or checking Google because, even we do NIH stroke scales in the emergency department, and that is a little bit of a longer go. So I always pull up an NIH stroke scale right next to me and go down it line by line. And so if you have to do that with the FAST-ED score, I think that's real good. That way you're documenting accurately the symptoms the patient's having, because we want to make sure that they are clinically indicated potentially for some of these interventions that we have, which are not, risk zero. And so it's important to make sure we're identifying these people. And then on top of identifying what symptoms they're having, the other most important things that we want to make sure we're asking and then documenting is time of onset. So we use the term last known well. So that means when was the last time the patient was seen totally normal, right? If they woke up with a stroke, then we're not really sure. So their last known well was really last night. Mm-hmm. That's a big deal when it comes to actually administering TPA in the emergency department. The other things we really want to know is what kind of medications they're on, because obviously if they're on an anticoagulant, then that also is a contraindication for TPA. So those information, the time and what medications they're on specifically, and specifically anticoagulation, are very important to finding out if they're a TPA candidate or not.
Absolutely. You might also hear last known well referred to as last known normal. Our golden hours for TPA tend to be under 3 hours. Golden hours for thrombectomy tend to be under 24 hours. So that window changes drastically based on what kind of information we get. And I from my experience, you guys have all been great about it, and we appreciate you and keeping that going.
Yep. And if anybody wants to talk stroke, happy to chat with us or Dr. Wagner.
Yeah, absolutely.
Thanks, guys.
Till next time.